Hi, I'm Dorothy Bulis. I work at Children's National Medical Center in Washington, D.C. Today I'll be talking about Transcranial Doppler pediatric applications. So the objectives of this talk includes reviewing the technique of transcranial Doppler, recognizing what normal blood flow patterns are, recognizing alterations in these blood flow patterns, and identifying applications for transcranial Doppler extending from as early as fetal life to brain death. Alterations in blood flow occur following asphyxia, trauma, subarachnoid hemorrhage, and there are many clinical indications including sickle cell disease, vasculitis, hydrocephalus, vasospasm, AV malformations, and brain death. We'll start first with the fetal applications of transcranial Doppler. The technique includes obtaining axial images of the brain and with color Doppler putting the cursor on the middle cerebral artery. You can get various measures including peak systolic velocity, pulsatility index, resistive index, and a cerebral placental ratio, which includes the middle cerebral artery PI divided by the umbilical artery PI. What occurs during mammalian diving reflex? The heart slows, peripheral vasoconstriction occurs, and there is central nervous system vasodilatation. All these occur. Thus, when a fetus is in distress, you may also see cerebral redistribution, where you see increase in MCA diastolic flow, and this ends up increasing velocity and decreasing the PI. Looking at the MCA, one can assess fetal anemia with an increase in peak systolic velocity and assess for intrauterine growth retardation by looking at cranial to umbilical ratios, which decrease when there is cerebral redistribution. So with fetal anemia, peak systolic velocity can increase when there is significant anemia, and this is quite sensitive, though there is approximately a 12% false positive rate. There are numerous studies have demonstrated the reliability of looking at peak systolic velocities to assess for fetal anemia. For intrauterine growth retardation, one sees a decreased perfusion to the fetus. Thus, there is a redistribution of blood flow with increasing diastolic flow to the brain. When we deal with the cerebral placental ratio, we're looking at the ratio of the MCA flow to the umbilical arterial flow. Typically, the ratio is over 1.45. This drops to 1 at about term. If the cerebral placental ratio is less than 1, the suggestion of placental insufficiency should be raised. We'll now move on to the neonatal technique of transcranial Doppler. With the open fontanelle, we have the advantage of directly looking at the vessels as well as looking at the brain. Here we have a case of a Venous Galen aneurysm beautifully seen by ultrasound. We can put the cursors on, demonstrating very high diastolic flow with multiple feeders into the Venous Galen aneurysm. Ultrasound can also be very useful after therapy. In this case, the infant has been embolized and we have successful obliteration of the Venous Galen aneurysm. We can also look not only at abnormal arteries, we can also look at the normal venous sinuses. With the linear transducer via the anterior fontanelle, one can see the straight sinus, the Venous Galen. In this case, we do not see flow in the straight sinus, and this turned out to have a sagittal sinus thrombosis secondary to dehydration. So venous sinus thrombosis can occur in several different veins, including the vein of Labbé, vein of Galen, and these can develop hemorrhage. Therapy tends to be supportive. Rarely anticoagulation is recommended. In this infant on the right, we do not see any flow in the straight sinus, so it's important to know what normal looks like. Beware when we see vessels that do not have flow in them, and that it may not necessarily mean there's thrombosis. You have to be very careful with your technique to make sure that we're not simply seeing a very dilated, slow-flowing vessel. It's also useful with transcranial Doppler in the neonate to look at the subarachnoid space. Typically, there are crossing vessels, and this can help to differentiate simply extra-axial collections that are subarachnoid versus subdural. With a subdural hemorrhage or fluid collection, the vessels are going to be plastered along the convexity of the brain. You will not see any crossing vessels, and the gyri may be flattened. We'll now look at the intracranial arteries. Via the anterior fontanelle in the sagittal plane, one can see the anterior cerebral artery. The pulsatility can be again assessed with peak systolic and diastolic parameters, which then can result in ratios including the resistive index. In the anterior fontanelle, moving to the right and left in the coronal plane, one can insonate the middle cerebral arteries. Here's a case where you see no flow on the left with normal flow on the right, and on CT we demonstrate that there was an acute left MCA infarct. After fontanelle closure, we no longer have the luxury of visualizing the vessels directly via the fontanelles. However, there are several windows that are available to us even in the adult population. This includes the transtemporal window, the orbital window, the submandibular window, and the foramen magnum window. The transtemporal window can be utilized either with the imaging or non-imaging transducers. With the non-imaging transducer, one can place the transducer directly over where the MCA is coursing. With sound, one can establish various velocity patterns, including establishing the peak systolic and diastolic and time average maximum mean velocities. Advantages of the non-imaging transducers are that they are relatively inexpensive. The probe is small, so it's easy to manipulate. There's high quality sound, which is critical in making sure you're in the center of the vessel. These are made specifically for transcranial Doppler, so there are toggle buttons for moving every 2 millimeters, there's summary data sheets, and can be actually quite fast in experienced hands. Problems with the non-imaging technique are that it does require intensive training. It may be hard to find the vessel simply by listening for it, and many centers do not have this machinery available. With imaging, where most radiologists now have ultrasounds that can give us both color and grayscale Doppler via the transtemporal approach. By throwing the color on, we often can see a beautiful circle of Willis. The first arrow is pointing to the left middle cerebral artery. One can see the anterior cerebral artery, the posterior cerebral artery. When you put the cursors on, you can get a Doppler signal that again gives us information including peak systolic velocities and diastolic velocities, resistive indices, pulsatility indices, time average maximum mean velocities. With the vessel coursing towards the transducer, the strongest signal comes from the middle cerebral artery. And you can march down this vessel every 2 millimeters to make sure that there are no areas of stenosis or narrowing throughout the vessel. At the level of the bifurcation, one gets flow away from the transducer, which is the anterior cerebral artery, as well as flow towards the transducer, which is the middle cerebral artery. This gives you a biphasic wave pattern, which in this case is the bifurcation. Angling slightly anteriorly and a little more distally, one gets flow in a reverse direction, and this is the anterior cerebral artery. If you angle the transducer inferiorly slightly, one can get portions of the distal internal cerebral artery, which has a slightly harsher pattern and sound. And when you angle posteriorly, one can get portions of the posterior cerebral artery. The velocity of the posterior cerebral artery tends to be somewhat lower than the middle cerebral artery. Going from the posterior approach, one can identify the basilar artery and the vertebral arteries. One can also view an orbital window and get ophthalmic Dopplers. So the ophthalmic artery also gives a typical waveform pattern. It's a slightly higher resistant vessel. However, when there's collateralization, one has increased flow in diastole and can help support the diagnosis of an internal cerebral artery stenosis. In this case, we have MR documentation that the ophthalmic artery is being used as a collateral due to narrowing of the distal ICA. So what are advantages of the imaging approach? Well, one can actually see the vessel, so quickly place the gate with higher confidence of what vessel you're seeing. It is a shorter learning curve, and most radiology departments have these transducers available. One can auto trace and, if necessary, can angle correct. Let's talk a little bit about our resistive indices. Now, this is a ratio of peak systole minus end diastole divided by peak systole. This helps minimize the effect of angulation. There are age-dependent values. In the preterm population, the normal RI is typically around 0.77. In term infants, just drops to about 0.7, and by age 2 to adulthood, the normal resistive index is 0.5. What does the resistive index mean? An increase in diastolic flow results in a decrease in the resistive index. This starts looking more like a venous pattern. A decrease in diastolic flow will result in an increase in resistive indices, and you may have actually no flow in diastole. As intracranial pressure increases above mean arterial pressure, diastolic flow may actually reverse, and you'll have an RI greater than 1. Factors that impact intracranial flow include stenoses, vasospasm, complete occlusion, head injury with increased intracranial pressure, changes in CO2, including simply crying or sleeping, and as I mentioned, age, where flow velocities can decrease with age and your resistive indices can change. So what are the applications of TCD? For the next half an hour, I'll be discussing its use in assessing for hydrocephalus, asphyxia, vasculitis, sickle cell disease, trauma, and brain death. The first question is, why should we use it? What is the actual clinical question? What are the presenting symptoms? And are there other studies that can help provide information? Do we need baseline exams for reference? Can this be done portably or in a vascular lab? And should we be using imaging or non-imaging transducers? And how experienced are the examiners who are performing this study? So for infants with hydrocephalus, it turns out that resistive indices can be quite useful in differentiating hydrocephalus from atrophy. When ventricles are large, they could be large simply from atrophy, but very often the neonatologist wants to know if there is hydrocephalus, which will benefit from lumbar puncture, tapping, or even a reservoir or shunt. In this infant, you can see there is no flow in diastole, suggesting that there is an increase in intracranial pressure. As increased intracranial pressure goes higher, you get less and less diastolic flow. If there's atrophy, the resistive indices will be in the normal range. When they're elevated, it implies the need for tapping or shunting. Go and all demonstrated that infants with resistive indices greater than 0.8 were at advantage of getting tapped or shunted because they did have increased intracranial pressure. What happens after a tap is the diastolic flow increases with a normalization of the resistive index. If there is continued hydrocephalus, you may not see a response to the taps, and that may imply a need to actually get a ventricular peritoneal shunt. Here we have a case of severe ventriculomegaly with reversal flow in diastole. After tapping, there is marked improvement in the diastolic flow. George Taylor went a little step further and noted that if you put compression on the anterior fontanelle in infants who have slight increase in intracranial pressure, you will actually demonstrate changes in resistive index. If there is normal, just mild ventriculomegaly, there will be no change in the resistive index. So here we have an example of an infant who, with compression, develops some reversal of diastolic flow, suggesting that there is increased intracranial pressure. One problem with the transcranial Doppler is you need to be aware of what the rest of the body is going through. So yes, the head is indeed connected to the body, and we need to be aware. So here we have an infant who has reversal of flow in diastole, yet the ventricles do not look particularly dilated. In this case, the infant had a patent ductus arteriosus, nothing to do with the ventricles. Here's another infant who had very elevated resistive indices. This turned out to have a hemangioendothelioma. So it's important to know the clinical history of the patient. Some studies have looked at hydrocephalus in adults. Unfortunately, there is a wider variation of normal, and it's more useful if baseline values are available, which typically are not. And you do need to have closer correlation with clinical findings. Joanna Siebart has done several studies looking at adults with shunt failure and did note that, as in this case, there was evidence of shunt failure with low diastolic flow. After the shunt was repaired, there was increase in the diastolic flow with a normalization of the resistive index. In this case, the resistive indices were in the normal range, suggesting that there was no increased intracranial pressure. We can also sometimes actually visualize abnormally high diastolic flow, which may be secondary to an arteriovenous malformation. Let's move on to asphyxia. Asphyxia can result in impaired cerebral autoregulation. This will end up with an increase in diastolic flow. This has become a very powerful tool in the assessment of a term infant following asphyxia. As I'd mentioned, normal resistive indices should measure approximately 0.7. When one encounters a low resistive index within 48 hours of an asphyxiated event, this correlates with poor neurologic outcome. So here we have a diffusely edematous cranial ultrasound. The RIs are low. This helps us to distinguish this from your typical brain just after delivery. And on follow-up, this indeed was an infant with hypoxic ischemic encephalopathy. Here's another infant with a low resistive index. CT again confirmed the severe HIE. Here, the sulci appear a little bit blurred. The thalami perhaps slightly echogenic, but these findings are quite subtle. The fact that the resistive indices were low helps to suggest that this is indeed hypoxic ischemic encephalopathy and was confirmed with MR. This has also been associated in children after head injury or cardiac arrest. This loss of autoregulation can again cause increase in diastolic flow and suggests impairment of the cerebral autoregulation and can be used to predict cerebral injury. One also notes that with low RIs, hyperventilation may fail to alter the waveform pattern, and that also suggests vasomotor paralysis, also a poor prognostic sign. Let's move on to ruptured intracranial aneurysms. Looking for vasospasm is something that is used quite routinely in the adult population with TCD, not as commonly in the pediatric population, as this is more rare. We know that after an arachnoid hemorrhage, vasospasm can start developing as early as 2 days after the bleed and may peak 2 weeks later. By about 3 weeks, this should subside. The first clinical application of TCD was in fact assessing for vasospasm. So here's a 17-year-old who has evidence of narrowing of both the ACA and the MCA. What happens as the vessels narrow, you get increase in velocity. And it turns out that TCD can be highly specific in identifying who is developing vasospasm before clinical symptoms develop. This can help guide optimal timing of surgery and therapy. And one can follow the velocities as they decrease, helping to time the appropriate occurrence of stopping therapy. Elevated velocities, as I mentioned, often precede the onset of the neurologic symptoms. And many centers now study the resistive indices and peak systolic velocities of the MCA daily in these patients. What should the protocol include? There's mild increase in your velocities, and as the vasospasm increases, this becomes moderate and then severe. If the peak systolic velocities rise to over 200 centimeters per second, there's a high risk for ischemia. A rapid change within a day or so of more than 50 centimeters per second also bodes for a poor outcome. One should perform both the right and left middle cerebral arteries daily, identifying the highest velocities and compare day to day. The proximal and middle cerebral artery is the most accurate in assessing for vasospasm. And as mentioned, rapid increase of over 50 centimeters per second per day, or an actual peak systolic velocity of over 200 centimeters per second, bodes for vasospasm. Remember, however, that there are other etiologies that can cause increased peak systolic velocity. This can include increased intracranial pressures. You can have abnormally low systolic velocities due to low volume flow, and there can sometimes be peripheral vasospasm. So it is critical to combine your clinical data and lab data with the actual TCD results. One can also use transcranial Doppler to assess for cerebral vasculitis. This small vessel vasculopathy is somewhat rare in children, but can cause acute stroke. Using transcranial Doppler, one can try to prevent further stroke by treating with prednisone or cyclophosphamides. One can also follow progression of stroke with TCD. A whole talk can be given on sickle cell disease. We know that children are at risk for cerebral infarction, and we know that stenosis of the internal cerebral artery, middle, and anterior cerebral artery can progress for years prior to stroke. So it's wonderful that we can indeed assess for stenosis risk prior to the actual stroke occurring. This screening includes looking at the peak systolic velocities and mean peak systolic velocities of the MCA, distal ICA, and ACA. The STOP criteria uses the mean peak velocity of the middle cerebral artery and distal cerebral artery if they range over 200 centimeters per second. The STOP study has demonstrated children that have abnormal TCDs had an abnormal risk of stroke of over 10%. With transfusion, stroke risk decreased to less than 1% per year. So there is now recommendations that we scan our sickle cell patients every 6 to 12 months. Let's show you an example of a child with sickle cell disease. In the right MCA, the time average peak velocity or time average maximum mean was 78 centimeters per second. On the left, notice how high it is. It's over 280. And indeed, this child did have a stenosis. Another 10-year-old came in for screening, was asymptomatic, and one can see that the peak systolic velocities are over 300. The actual time average maximum mean velocity measured 370 centimeters per second. And one notices that actually on the right, the velocities were unusually low. MR demonstrated absent flow in the right ICA with proximal stenosis of the left MCA. The patient was immediately started on transfusion therapy and has remained stroke-free. One does need to worry about low transcranial Doppler velocities progressing to occlusion. So beware if the velocities are less than 70 centimeters per second in the MCAs, in the time average maximum means, that could suggest a tight stenosis as we see in this patient. We can also suggest moya-moya disease on transcranial Doppler when we do not see a normal middle cerebral artery and a cluster of vessels. We'll now move on to traumatic brain injury. There are pathologic processes that result in significant changes in cerebral hemodynamics after trauma. Timely diagnosis is crucial in head injury management. Acutely, there may be a decrease in the resistive index due to loss of autoregulation. The vessels may vasodilate. After cerebral blood velocities can start increasing due to vasospasm because of subarachnoid hemorrhages or hypervolemia. When cerebral edema develops, resistive index will continue to rise. As edema increases, you get less flow in diastole, and you may actually get reversal of flow when the intracranial pressure increases above mean arterial pressure. So here we see a pattern of trauma where initially there's some vasodilatation with increased flow in diastole. You then get a drop in the diastolic flow, and as the cerebral edema worsens, you actually get reversal of flow in diastole. This can progress to brain death. When there's such an arrest of cerebral blood flow at the microcirculatory level, the large vessels distend, thrombose, and then collapse. Eventually, you get virtually no antegrade flow in either systole or diastole, and you have complete circulatory arrest. So let's look at this again. Following trauma, resistive indices can be separated into 4 categories. There may be no change. You may get an increase in RI with no flow in diastole. You may actually get a reversal of flow with the diastolic flow below baseline, or you may see no flow at all. So here's an infant, it was actually a child who had no flow in the intracranial vessels. This is already equal to brain death. When there's reversal of flow, if the fontanelle is closed, this pattern typically progresses to brain death in the next 24 hours. And here you can see confirmation with a nuclear scan. In children after trauma, where there is elevated resistive indices with very little diastolic flow, they may be cerebrally significantly neurologically devastated, but survival is usually typical. And if someone comes in with normal resistive indices, again, there may be neurologic deficits, but survival is most likely. So serial TCD readings can evaluate how severe the edema is and follow the course of therapy. We can see if there is vasoreactivity. If there is reaction to hyperventilation, that bodes for a better prognosis than those who do not react to the hyperventilation tactics. So RI increases as the vessels vasoconstrict due to decreasing CO2. This suggests reactivity. If there is reduced or absent CO2 reactivity within 24 hours of an injury, this has a very poor outcome. Again, cerebral edema can increase resistive indices, so you have to correlate with clinical and lab findings. So here we have severely injured child. Is this brain death? Nuclear medicine has been used to assess for brain death, but needs to be repeated if some flow is shown, and needs to wait 24 to 48 hours to repeat this exam. We can use other modalities such as CT or an angiogram, but they're quite invasive. Ultrasound is a quick way of seeing whether any of these additional studies need to be performed. So establishing brain death can be problematic, and we have apnea tests, EEG, brainstem evoked potentials, nuclear blood flow studies that all can be used to help the condition determine brain death. TCD can add another non-invasive method of determining brain death, and it is not affected by phenobarbital. So it's non-invasive, repeatable, portable, inexpensive, easy to perform. So here we have a patient who has to and fro reversal in diastole, severe brain injury. Reversal of diastolic flow can be characteristic of essentially absent effective cerebral circulation in the adult and older child. Remember, however, that there are cases where mild diastolic reversal flow have recovered. So Kirkham suggested using a direction of flow index. In this, the formula is 1 minus peak systolic velocity divided by peak diastolic velocity. If the DFI is negative, the area of reverse flow is greater than forward flow and bodes for a poor outcome. If there is a negative DFI, and this is repeated over 30 minutes, all of them died without brainstem function recovery. So let's look at some brain death patterns. In these cases, you have very small early systolic spikes, so there is arrest of antegrade flow as well as reversal of diastolic flow. Here, there is virtually no flow documented in the intracranial vessels. Here are some additional examples: very high spiked, minimal flow in systole with reversal flow in diastole, with the velocities dropping over time. Here again, some additional examples with very low systolic velocities and reversal in diastole. Infant brain death is a particular problem in assessing, and TCD also doesn't work as well as with the pediatric population and adult population when the Fontanelle is already closed. In the neonate, low resistive indices have been described in clinically dead patients, and in the other extreme, infants with extremely high RIs have survived. So again, careful clinical correlation is crucial in determining brain death. We are looking at supratentorial blood flow. This is not synonymous for brain death. Rather, it is confirmatory. So when we think about using transcranial Doppler for brain tests, it's not to be used in isolation, and it should not be used to supplant clinical neurologic findings. However, it does provide data that can help indicate the severity of the cerebrovascular arrest. If there is any question, repeating the study can help to confirm that there has been sufficient irreversible damage to the supratentorial structures. So in conclusion, I hope I've shown to you that transcranial Doppler can be used to monitor children with severe head injury because it's portable, non-invasive, rapid, and can be repeated often. It provides useful adjunct in many clinical assessments of not only the injured patient, but the patient after vasospasm, after hydrocephalus, and after stroke. Remember that transcranial Doppler is your friend, and try to use it as often as you can. Thank you.